Hi everyone, my name is Thipiga Sivayoganathan. I'm a graduate student from the University of Western Ontario, and today I'll be presenting my study on trends in mental health service use among youth and emerging adults in Canada to inform policy decisions. So adolescence and early adulthood are transitional life stages that involve changes in social roles, taking on new responsibilities, and establishing independence. However, the number of people living with mental illness is highest for this age group. 50% of lifetime cases of mental disorder start by age 14 and 75% by age 24. Despite the high prevalence rates for mental disorders among youth and emerging adults, only a minority of this population receive help from mental health services, and many report unmet need for services. While rising prevalence of mental health problems and service inaccessibility is a public health issue, it's also costly for the economy. A report released in 2011 detailing the economic impact of mental illness in Canada estimated the total economic impact of mental health problems in 2011 to be $48.7 billion and rise to an annual amount of $307 billion in 2041. These projections are considered to be an underestimate of true costs because they don't include costs to the justice system, education, child and youth services, and other public service costs. Considering these extra spending on effective mental health care services should be viewed as an investment in the economy rather than an expense.
In response to the mental health crisis in 2017, the federal, provincial, and territorial governments agreed to the Common Statement of Principles on Shared Health Priorities, which emphasized improving mental health services. The federal government committed to providing the provinces and territories with $5 billion in funding over 10 years and identified expanding access to community-based mental health services for children and youth as one of the major action plans.
To improve access to mental health services, relative access to providers is also an important consideration. There is a large variation in the supply of different types of healthcare providers available to provide mental health care in Canada, which can impact service accessibility. In 2017, there were 143 social workers per 100,000 people in Canada, yet only 14 psychiatrists. This variation matters because different providers receive different types of training in mental health service provision that translates to different scopes of practice. For instance, family physicians and social workers don't have clear standards for demonstrating competency in psychotherapy, which is one of the most evidence-based lines of treatment for mental health. Further, across Canada, physician-provided mental health care is covered by the universal healthcare system, but psychopharmaceuticals that they prescribe may not be. Additionally, psychotherapy services provided in private clinics, where a majority of psychologists and counselors are employed, require patients to pay out of pocket or access private insurance. This two-tiered system may result in differences in the type of mental health care providers that are accessed by individuals and the treatment received. As such, the current project examined trends in mental health service use, including the types of provider access among youth and emerging adults aged 12 to 24 years in Canada from 2011 to 2016. Time trend studies can be especially informative as they reveal changes in the type of services used, which can inform transitions from youth to adult services and identify areas for additional investment of resources to create a more effective mental health care system. Our first objective looked at trends in mental health service use for youth and emerging adults. To examine how people are accessing services, our second objective looked at trends in type of provider visited for mental health reasons. Under this objective, we estimated the proportion of youth and emerging adults who went to each type of provider and the proportion of service users that accessed one versus multiple types of providers. Additionally, to compare the type of provider access with provider supply, we also looked at the number of users per one health provider of that type, hereafter referred to as the provider's caseload. Next, I will provide an overview of the methods. I conducted secondary data analysis of the Canadian Community Health Survey, a population-based cross-sectional survey conducted annually by Stats Canada to gather health-related information at regional and provincial levels of the government. Data from the CCHS cycles conducted annually from 2011 to 2016 were used as they included 6 CCHS cycles, as well as the mental health module of interest. To produce the most accurate results and limit the ability of any one province with a large sample size to dispute findings, we selected multiple provinces with large sample sizes and examined data from the same set of provinces each year. These provinces were British Columbia, Manitoba, Ontario, Quebec, and Newfoundland. Participants were respondents aged 12 to 24 years with a valid response to the mental health service use item. Estimates for the number of healthcare providers in Canada were taken from data tables collated by the Canadian Institute for Health Information using data from the Health Workforce Database as well as the Scots Medical Database. This table shows a list of the outcome variables examined in this study. All prevalence estimates for mental health service use, types of providers, and number of providers seen were weighted, and balanced repeat replication was used with 500 bootstrap weights provided by Stats Canada to estimate 95% confidence intervals for valid variance estimation. All CCHS-derived prevalence estimates were age-sex standardized using the 2011 Canadian Census as the standard population. To test for significant differences, we used a method recommended by Cummings 2009, which used 50% proportion of overlap between confidence intervals of two estimates as indicative of a statistically significant difference at a p-value of 0.05. This method allowed for multiple comparisons between different pairs of years rather than assuming a linear trend. For our second objective, we examined type of provider access compared to provider availability by calculating provider caseloads in 2011 and 2016 for the four major types of mental health care providers in Canada. This includes family doctors, psychiatrists, psychologists, and social workers. We first calculated the proportion of people who sought each provider type per 100,000 using CCHS data and divided this estimate by the number of providers of that type per 100,000 people to provide an estimate of the amount of mental health users per one health provider of that type. Next, I will be discussing the results for each of our objectives. For Objective 1, Trends in Mental Health Service Use, our results showed that from 2011 to 2016, the prevalence of mental health service use increased significantly from 11.5% to 15.8%. For Objective 2, Trends in Types of Providers Seen, prevalence estimates for type of provider consulted with for mental health concerns as a proportion of the population indicated that across all years, family doctors were the most often consulted with professional, followed by social workers and counselors, psychologists, psychiatrists, and lastly, other health professionals and nurses. Trends in the number of different providers consulted indicate that across all years, most people spoke to one health provider type about mental health concerns. Next, we calculated the number of users per each type of health provider. In other words, a provider's caseload, focusing on the four major types of providers. For both 2011 and 2016, this table shows the number of users and the number of available providers per 100,000 people, as well as the provider's caseload, and the percent change in mental health service users and provider supply per 100,000 people from 2011 to 2016. We found that relative to other providers, psychiatrists had the highest caseload of clients, followed by psychologists in both 2011 and 2016. The number of users seen by these providers further increased from 2011 to 2016, yet the number of providers increased marginally for psychologists and not at all for psychiatrists. Social workers had the smallest caseloads relative to other providers, but they had the greatest increase in number of service users from 2011 to 2016, as well as the greatest increaser in provider availability. Family physicians had the second lowest caseload for mental health service users in this age group relative to other providers. They also saw the smallest increase in number of service users and a marginal increase in provider availability. Based on these results, our policy recommendation is to invest strategically in the provision of mental health services based on provider type. Our results showed a high demand for psychiatrists and psychologists among youth and emerging adults, but the rate of provider supply is not meeting the growing demand for these provider types. With the focus being increasing accessibility and affordability of psychotherapy services in most provincial initiatives, it's important to recognize that the providers who provide the most evidence-based psychotherapies are psychologists. More investment is needed to increase the supply and accessibility of these healthcare providers. Second, the increase in number of users who visited social workers in 2016 may indicate an increased willingness among youth and emerging adults to seek these providers for mental health concerns. Social workers could be an important resource to increase mental health service accessibility. Third, though family doctors had the highest overall rate of service contact in all years, by 2016, social workers and counselors as well as psychologists were closing the gap in the overall number of users they saw, suggesting a shift in provider preference among this age group. Considering the national shortage in primary care providers generally and the lack of mental health specific training for this provider type, other mental health care providers may be able to fill this gap through collaborative care. Different types of health providers have various skills and qualifications that must be considered to be more effectively investing in the provision of mental health services and coordinated care. This concludes my presentation. Thank you for listening.